Good afternoon and welcome to today's webinar, Procalcitonin Testing and Molecular Pathogen Detection, a Value Model. I am Lisa Dunay and I'll be your moderator for today's event. We are delighted to bring you the LabLeaders webinar series presented by AACC and supported by a generous grant from LabLeaders. This program is accredited for Accent Continuing Education credit. I would like to point out that we are hearing some background noise, so if everyone who is participating on a phone could mute their line, we would greatly appreciate it. I'd like to point out that the webinar will conclude with a Q&A session. You can submit your questions at any time during the webinar through the Q&A dialog box in the bottom right-hand corner of your screen. However, questions will not be answered until the end of the program. Please note that in the right-hand corner of your screen, you will see a dialog box labeled Q&A as well as a chat dialog box. To ensure your questions are received, please only submit through the Q&A box. Now, to make sure your Q&A dialog box is open, please confirm that it is visible in the right-hand corner of your screen. If it is not, simply click the Q&A icon from the options in the bottom center of your screen, and it will turn blue. Your Q&A dialog box should then become visible. So let's get started. As a global leader in healthcare, Roche Diagnostics has made the promise to empower laboratories and the people within them by providing clinical and strategic insights, support, and solutions from the industry's top innovators through lableaders.com. So again, we thank you for joining us today for this LabLeaders webinar, Procalcitonin Testing and Molecular Pathogen Detection, a Value Model. Our speaker is Dr. Tran, who is an Associate Professor of Clinical Pathology and the Director of Clinical Chemistry, Special Chemistry and Toxicology, and Point-of-Care Testing at the University of California at Davis. He completed his PhD degree at UC Davis in Comparative Pathology in 2008. He then conducted a postdoctoral fellowship with the National Institute of Bioimaging and Bioengineering through support from the UC Davis Point-of-Care Technology Center. His postdoctoral research focused on developing novel molecular technologies for bedside testing of infectious diseases. These studies translated to a large multi-center trial evaluating the clinical impact of rapid molecular testing and sepsis in severely burned patients. Dr. Tran, you may now begin your presentation.
Wonderful, and thank you for that wonderful introduction. Again, I'm Nam Tran, and good morning or good afternoon to everyone in the audience, wherever you may be. So again, we're going to talk about procalcitonin and molecular pathogen detection today, but from a different perspective, and a perspective that we as laboratorians, lab leaders, and so forth need to really focus on, because this is really where the field's going, and this is all about value, right? So it's not necessarily the cost per test. It's not necessarily how fast we can do it. It's more so the value that we contribute to the healthcare system and so forth, especially as now it relates to these topics of procalcitonin and pathogen detection. So we have a couple of learning objectives here. The first is really to give an overview of the use of these tests, especially as it relates to antimicrobial resistance and antimicrobial stewardship, or AS. We're also bringing a new abbreviation called antimicrobial stewardship programs, or ASP, so just kind of get everyone caught up on the abbreviations. We also want to talk about the regulatory requirements for antimicrobial stewardship that's now in place. It's moving along. It's real. And we also want to talk about how using procalcitonin and best-in-class polymerase chain reaction or PCR testing promotes antimicrobial stewardship. And lastly, but certainly not least, the value aspect that I brought up earlier, the health economics, the metrics, the implementation of how we can actually drive patient care towards a value-based model. So let's bring the story of antimicrobial resistance up. This is a public health crisis, as we know. It is not new. We've known that organisms are a lot smarter than we are, and they are able to adapt more quickly than we can develop new medications to destroy them. So in this case, resistance, as we know, we have various threats out there, urgent threats, serious threats, and concerning threats. Urgent threats such as Clostridium difficile, carbapenemase-resistant Enterobacteriaceae, and of course, the ongoing and accelerating issue of drug resistance, resistant gonorrhea. Just last week, we now see the development of new drugs and potentially coined as our last line of defense against resistant gonorrhea because the resistance in this pathogen is going out of control. We have serious threats that are typically encountered in the inpatient population, especially amongst those that are immune compromised and so forth, but this includes multi-resistant Acinetobacter. This organism resonates with us significantly at UC Davis because we are one of the larger burn centers in the U.S. and definitely one of the larger burn centers in California. And this population, along with our transplant patients and so forth, encounter this organism, this multi-drug resistant organism, quite often. We also see fungal species becoming resistant. So Candida, fluconazole-resistant Candida, is now becoming an issue. ESBLs, or extended spectrum beta-lactamase producing Enterobacteriaceae, are problems. And of course, we see our concern for VRE, vancomycin-resistant Enterococcus. And we've always been concerned about this organism transferring a little bit of its genetic material to MRSA, or methicillin-resistant Staph aureus, to generate VRSA, as we've always worried about. In the news also recently, we've also seen that VRE has, in some variants of it, are also resistant to alcohol. So washing your hands, cleaning surfaces with alcohol, some VRE species may be robust to that, something that we've always thought as impossible to be resistant to. So the issue now ultimately focuses on 4 core actions, and we'll discuss this in detail as we'll identify various regulatory movements and so forth. But first and foremost, preventing infections, preventing the spread of disease. So we want to prevent the infection to happen in the first place, and if people do have resistant organisms, we want to potentially isolate and prevent the organism from moving on to other patients and locations. Tracking as in creating situational awareness, knowing trends. The CDC gathers data on resistant organisms, and locally at your institutions, you should be gathering data, generating antibiograms, and so forth, and knowing these trends determine how our antibiotic pressures are pushing certain organisms towards these threats, as we see on the right. Improving antibiotic prescribing and stewardship, extremely important, highlighted here in yellow. And of course, we know full well that unnecessary use of antibiotics, excess use of antibiotics, promotes these issues of organismal resistance. And last but certainly not least, the things that speak very highly for me is development of new drugs and diagnostic tests. We want to be able to not just improve our practices, but we need to have ways to obviously treat new resistant organisms, but have an evidence-based approach, and that's the diagnostic test that we all hold so dear in our laboratory world. So here's some quick statistics. We know that antibiotics are overused, but how much? Studies have shown that up to 50% of antimicrobial use in acute care hospitals is unnecessary. The unnecessary use of these antimicrobials leads to obviously the resistant bugs that I just mentioned, including C. difficile, ESBLs, and CREs, but also, and often sidelined, toxicities and adverse drug events. Any drug can have some sort of side effect. And toxicities that we've known full well in terms of antimicrobials include nephrotoxicity, as well as other sequelae that can occur. A good statistic that we are very much aware of at UC Davis is our burn patient populations again. Studies at our institution have shown that over 58% of burn patients acquire acute kidney injury during their stay, with the large proportion of these events of AKI attributed to or exacerbated by the administration of nephrotoxic antimicrobials, such as the aminoglycosides, amphotericin B, and to some extent vancomycin. with these additional toxicities, adverse drug events, you can increase morbidity, extend hospital stays, so unnecessary hospital days. It could delay the starting of appropriate antibiotics. When you give patients 2 or 3 antibiotics that they may not need, we may not think about looking at if the drugs work, and we may delay initiation of drugs that are targeting the resistant organism. We may wait out a couple of days. Well, maybe we just need to wait out a couple of days for these drugs to take effect when, in fact, the organism is resistant to it. And then, of course, also with all these combined, it reduces the cost effectiveness and also the efficiency of healthcare delivery. I do want to add into this that a large part of these issues also come about from the outpatient population, not just in the acute care side. That studies have also shown that a lot of the inappropriate antimicrobial use also come from, in large part, from urgent care centers out there. So we have to push an effort for people to understand across the entire range of healthcare, not just in acute care hospitals. So from a regulatory standpoint, we finally got the legislative pressure in September 2014 with the White House issuing an executive order for combating antibiotic-resistant bacteria. March 2015, we see that this National Action Plan for Combating Antibiotic-Resistant Bacteria identified multiple goals, with 2 goals that resonate with us in the community. And the first, of course, is advanced development of point-of-need diagnostics. It's great that we have technologies that are located in the laboratory. It's great that we have advanced technologies that are located in the laboratory, but we now need to move these tests towards the point of need. And as I alluded to in the last slide, this overprescription of antimicrobials, the emergence of resistant organisms, is not just in acute care hospitals. It's also located within our outpatient clinics, urgent care centers, and beyond. And goal number 5 right here also highlights in this document enhanced antimicrobial stewardship. So both of these go hand in hand, because to be able to provide stewardship, we also need the evidence, the objective evidence, and that comes from these diagnostic tests and all that data that we work with. June 2016, CMS, or the Centers for Medicare and Medicaid Services, issues proposed condition of participation requiring antimicrobial stewardship in hospitals. So it's now written in there that we're going to have some sort of AS or antimicrobial stewardship program to be able to meet CMS requirements. Joint Commission took it a step further. They began surveying hospitals in January 2017 for compliance with antimicrobial stewardship standards. In 2018, all acute care hospitals per CMS that are participating in Medicare and Medicaid services must implement these ASPs, or antimicrobial stewardship programs, and have released interpretive guidelines, which we'll talk about. By 2020, it's envisioned that all healthcare delivery systems will demonstrate antimicrobial stewardship. It's no longer the Wild West where everyone has a chance to just give whatever they want for antibiotics. So what are the CMS guidelines in this case? What are they requiring us to do? The good news is that it's flexible. Bad news that it's kind of vague. So that leaves us to be leaves a little bit for interpretation there. You can see here that these 5 elements: develop antibiotic stewardship policies and procedures, demonstrate ASPs implemented hospital-wide, improve coordination amongst all stakeholders involved in antimicrobial use and preventing antibiotic resistance, document evidence-based antimicrobial use, and demonstrate reductions in adverse effects from antimicrobial use, specifically for C. difficile infection and antibiotic resistance. That sounds great. But the how, when, and where. So, for example, demonstrate ASP implemented hospital-wide. Great. It's implemented. Is it really working? Those are questions that you have to think about. So it is flexible. You can do whatever you want, but a little bit vague, especially for smaller institutions that may not be familiar with this. If you look into the more details for this worksheet from CMS, you can see that from the procedure standpoint, they ask for the hospital has to have a formal procedure for all practitioners to review the appropriateness of antibiotics prescribed after 48 hours from initial orders. Great. The hospital monitors antibiotic use at the unit or hospital level. Great. What should we be monitoring? How? Again, who, what, where, and why? Those main questions we have to ask. Fortunately, the Joint Commission has done a little bit of better interpretation and pushing us to a higher level of performance. In this case, they use the CDC's core elements of hospital antibiotic stewardship programs as a guide for their checklist, and it's far more extensive, but fortunately also more detailed than the CMS checklist that you saw previously. In fact, here are some examples. It includes assessment of appropriate antibiotics for community-acquired pneumonia. So it tells you what you need to do and who you're looking at. Guidelines for antimicrobial use in adults. Guidelines for antimicrobial use in pediatrics. Assessment of appropriateness of antibiotics for skin and soft tissue infections, and the list goes on. So ultimately, they want us to take action that we implement the policy or generate practice changes to improve antibiotic use. That's their ultimate goal here. So with this said, this is where the technology comes in. And oftentimes, being laboratorians, we love the technology. I came into this field because of the technology, but we should never let technology guide the need. The need has to guide the use of the technology. In this case, the use of these new tests that have become available in the United States over the last couple of years. So procalcitonin and molecular point of care testing, so MPOCT, especially those using PCR, to promote antimicrobial stewardship. The intent here for these technology is to address the need for allowing these clinicians to decrease unnecessary use of antimicrobials, initiate correct antimicrobials earlier, reduce adverse effects of these antibiotics, improve outcomes, of course, and reduce antimicrobial and healthcare expenditures, and ultimately be compliant with these regulations that you've seen already. So what's procalcitonin? For those that attend the AACC meeting, the critical care meetings, you've heard about it. It's out there. And I would say that UC Davis, we've been hearing about this for probably about over a decade. And it's a biomarker that originally was used to some extent in Europe. The literature supported its potential use in the field of detecting bacterial sepsis. And this is a nice slide here that illustrates, published a while back, that shows how procalcitonin comes about in terms of infection. As the name implies, it's a prohormone to calcitonin, but it's not cleaved in infection. In fact, it's produced by multiple other cells, not just C cells, in the context of bacterial infection. So when this biomarker was first became available, most folks thought this was going to be great for looking at bacterial sepsis, early recognition, early biomarker, by analogy, the so-called troponin, I put in quotations, troponin of sepsis. And we'll see that it hasn't really panned out to that, but it does have other uses, especially as it relates to how it can differentiate between bacterial versus viral infections. In this case, PCT doesn't rise in viral infections due to interferon gamma actually suppressing the production. But like troponin and many other biomarkers out there, it's not perfect. And in this case, we do see procalcitonin rising in certain populations, such as those with tissue injury and so forth. Looping back to our burn patients at UC Davis, procalcitonin is actually a little bit higher in normal patients for that group. So again, you got to use your brains to figure out if these biomarkers are doing what they're supposed to do and taking it within the clinical context. As literature progressed, it was found that a large amount of evidence supported its use in dealing with patients with upper respiratory tract infections, especially that population, to some extent pneumonia, COPD exacerbation, and acute bronchitis, and of course severe sepsis and septic shock. Still lots of questions coming up, but it has found good use in that respiratory tract infection role. Moreover, we see that procalcitonin plays a very important role in guiding the duration and perhaps de-escalation of antimicrobials in these patients, especially in the ICU population. And this relates ultimately to antibiotic stewardship. From these three meta-analyses and systematic reviews, we see that the use of procalcitonin-guided algorithms, again, to guide the duration of antibiotics and so forth, we see that there's a decrease in antimicrobial exposure of about 19 to 38%. That's a very significant reduction. We see no increases in mortality, length of stay, or relapse infection. So by reducing the use of antibiotics, in this case with PCT, it still didn't affect mortality, morbidity, and so forth. So ultimately, we see more rigorous evidence for de-escalating antibiotics versus starting antibiotics. So again, coming back to that notion I mentioned, that originally we thought PCT was going to be like the troponin of sepsis. It helps us identify sepsis, start antibiotics early, but it seems it's been flipped around a little bit in that it seems to have a better use in de-escalating once we've already recognized infection and started treatment. Here's the kinetics of PCT. So we're using a little bit, this is an older slide, but this is something we put together a couple years back where the old terminology, SIRS and so forth, still exist. But in short, x-axis is time in hours following exposure to an organism that causes sepsis. Y-axis is the concentration of each of these biomarkers with their respective units. And you can see C-reactive protein, lactate, tumor necrosis factor alpha, interleukin-6, and so on, but also PCT. I want to throw out there that we see that CRP, which is still used in some cases, and I've seen a recent paper that suggests that CRP still has a role. I'm not too confident in that because you can see here looking at the kinetics, it takes a while for it to rise in terms of sepsis and plateaus out 48 hours later. In contrast, we see that PCT does have a nice linear rise that's early, starting at about 2 hours, and goes up higher and higher as disease severity increases. And it also works well with lactate, which you can see here with the actual black line, solid line. And you can see that that also rises quickly, and those work together quite well, and that's what folks have been using in more recent times. PCT ultimately appears within 2 to 4 hours following infection, peaks at about 8 to 24 hours depending on the severity. Its half-life is about 24 hours and decreases by 50% over that time period if effective therapy was given. And as we would guess, PCT returns to normal once the patient recovers, so that's a good thing. The other thing that early studies have shown is that the higher the PCT that you have at admission, when admission for sepsis, the worse off you're going to be. So in one study, we see that an average PCT at ICU admission of about 2.4 nanogram per ml is predictive of survival versus those that have a mean PCT at ICU admission of 19.2 nanogram per ml. What we're going to focus more on today is the fact that if you see a decline in PCT of equal or less than 80% when the patient has severe sepsis or septic shock, that's not a good sign, especially over those 4 days, because they're not decreasing that PCT fast enough, which indicates that the persistence of that infection. There's a higher 28-day mortality for those patients, in contrast to patients that had a greater than 80% decrease in terms of PCT over that same period of time. Cutoffs that have been used for PCT in the past, typically values of greater than 2.0 indicate a greater risk for severity versus patients who don't have potentially infection or maybe have SIRS. These are values of less than 0.5 nanogram per ml. So going back to all the data, and this is a Cochrane review database, you can see here there's been a lot of studies that looked at procalcitonin to initiate or discontinue antibiotics in respiratory tract infections. And this is where all that data pushes now the focus of PCT in this cohort. So about 26 RCTs have been conducted, summing up to about greater than 6,000 patients. Procalcitonin versus usual care, standard care, that's usually the model of these studies. They looked at 38 mortality, and they found that 30-day mortality was significantly lower in PCT-guided patients. Patients who had PCT, they typically had an average reduction of 2.4 days of antibiotic days, and they had fewer antibiotic side effects. Makes sense. They had less antibiotics. This is 16 versus 23%, and there were no difference in treatment failures. So it seems to be safe and efficacious and clearly highly impactful for this large amount of data. But we now have another problem. We have a problem of overcalling pneumonia. So this means that we're going to have more people that may be treated unnecessarily for pneumonia, and oftentimes, as the theme of this talk is about, they may get unnecessary antibiotics because of this. So trends in hospitalization for pneumonia amongst persons 65 years or older in the United States, this is over 1988 to 2002. And so we see actually a 15 to 20% increase in these calls. Recent decreases, great, but when combined with sepsis and respiratory failure for these diagnoses, it's starting to rise. What's scary is this incidence of soft diagnosis of pneumonia that is potentially growing. That's when patients are often given a diagnosis of pneumonia without any signs or symptoms of pneumonia. Not so great. And typically, as practice is prompting and maybe perhaps patient pressure is prompting this, the diagnosis of pneumonia justifies, quote unquote, the use of antibiotics. Again, without any real evidence that there is a pathogen involved or that there is a pathophysiological mechanism ongoing that shows that there is a physiological response to infection. I have to say that I read a paper not too long ago that showed that in some patients, some patient populations, the patients may even bully physicians, feeling the pressure to have to get antibiotics just because they feel that they need it for a respiratory tract infection and so forth. So we live in challenging times, but now we need a call to action to be able to identify objective means to guide appropriate use of these antibiotics. So in this case, this is a paper from 2009 published in JAMA, and this uses procalcitonin for lower respiratory tract infections, or LRTIs. And you can see here, this is a very objective, systematic way to be able to guide the use of antibiotics, with PCT playing a central role. And you can see 4 categories. You have a PCT of less than 0.1 microgram per liter, between 0.1 to 0.25 microgram per liter, and these 2 cohorts, bacterial etiology is very unlikely. You're more likely to have a viral infection and so forth. You don't need antibiotics. Conversely, if you have values of greater than 0.25 microgram per liter of PCT, bacterial etiology is very likely as you get to higher values, then you definitely need to start antibiotics. But I do want everyone to focus on the bottom right-hand corner right there. It's not a one-shot deal. You're good to go. You have antibiotics. There is a check and balance mechanism in place that if antibiotics are initiated, PCT needs to be repeated on days 3, 5, and 7, and then it goes back into the same algorithm again. So if your PCT value actually drops below, you can stop antibiotics and so forth. So with this algorithm, used in a multi-center, non-inferiority randomized trial among 6 tertiary care hospitals, summing about greater than 1,300 patients with LRTI, COPD, community-acquired pneumonia, and acute bronchitis, there's a 90% compliance to this algorithm, which is hugely important because you can't have a good program without compliance. They found a reduced mean antibiotic exposure of 32 to 65% and reduced the rate of antibiotic prescriptions by 8 to 27%. That's profound. So it clearly shows if you have high compliance, a systematic way to do this, and objective means to guide antibiotic use and de-escalation, you're going to have big improved outcomes and, of course, easily meeting the antibiotic stewardship requirements from CMS and Joint Commission. But that sounds great from all these papers. As laboratorians, we're faced with other challenges too, which sometimes the bedside folks may not fully appreciate. If you roll back to 2014, and even before that, at UC Davis, we were challenged with the question, can we deploy procalcitonin? And if you were to talk to our clinicians, it would be, no problem, let's do it tomorrow. It's ready to go because it allows us for early recognition of sepsis, improved emergency department workflow, it clearly decreases hospital and ICU lengths of stay, it improves therapy management, and clearly that translates into financial savings. And I'm not arguing against that. However, if you talk to everyone before 2014, during the time when we were looking at things, we have a lot of challenges. And in this case, there's no automated test and so forth that's not available. And so we have a challenge right here that leads to increased costs. It's not automatically compatible with total lab automation at the time. We have to buy instruments, reagents. But in contrast, we are tempered with the fact that we decreased send-out PCT testing because that's what we were doing at the time, costing hundreds of dollars per test, and bringing it in-house increases testing revenue. So the question we asked ourselves as we waited for years and years and years, will there ever be an automated solution? Will there be a platform that sits on our total lab automation that we spent millions to invest in? Would it work on that to provide the throughput and turnaround time needed for our bedside clinicians? So fortunately, an automated process became available around the 2017-2018 timeframe. I do want to add in there that UC Davis did adopt a non-automated automation compatible platform in 2014. We only offered the test for same day. We could not have the turnaround time that was necessary for stat testing until 2017-2018, where an automated solution is available, connected, or being close to our automation line. So our value proposition for the institution was quite straightforward, and we had many others to go with this, but the one that resonated a lot with our clinicians was, that's great. If you have a patient that comes in with suspected sepsis, infection, and so forth, we can enhance that workflow by optimizing laboratory testing, and that complements antibiotic stewardship with diagnostic stewardship. So let's hypothetically say we didn't have PCT. A patient comes in, we evaluate them with the quick SOFA score, SIRS criteria, etc., and they met them. The electronic health alert system goes off saying this person could have sepsis, so you draw the whole spectrum of labs, including blood cultures, and to be honest, being pressured to initiate treatment early, you start antibiotics right after collecting the cultures. Guess what? 5 days later, cultures confirm negative. So great, you start antibiotics unnecessarily. You cultured unnecessarily. You probably drew additional labs maybe that were unneeded, but culture's been sitting around for 5 days. And I advocate for our microbiology colleagues, it's still a very manual process to figure this out. Yes, a negative culture doesn't have much work to do with it, quote unquote, but it's still work. It's still extra blood. And for those that recall how much blood we need for blood cultures, that's a lot of blood. So let's look at this figure on the left right here. So with procalcitonin sepsis workflow, enhanced sepsis workflow, you see that, yeah, the patient comes in with the SOFA score, SIRS criteria, but now just with one or two tests, we see that we have an abnormal PCT, so possible bacterial etiology right here. Lactic acid's elevated, so we're now meeting some of the SIRS criteria as well as sepsis criteria, depending on what you use. So it prompts us to actually order and initiate the various measures we would do, including cultures and antibiotics if needed. Great. And even if the blood cultures became negative, I'm still happy with that because we had a high probability that we need to test this patient. We improved our pre-test probability with PCT and lactate to be able to properly justify the use of cultures. In contrast, let's just say PCT was normal and lactic acid were normal. Maybe it's another issue. So in this case, the clinician may choose not to culture and work them up for other causes of SIRS in this case. And let's just hypothetically say that it's $50 for culture. I know for those that do know the numbers, it may be more than that. It depends on your institution. But let's say there's 1,000 cultures per year, and if we were able to save 1,000 cultures per year, that's $50,000. You just paid for the analyzer. You paid for a lot of things in that case. And again, this isn't including many other potential benefits of PCT that's already been documented in literature. So this was able to allow us to adopt this platform very quickly. We were one of the first to adopt an automated solution for PCT in our system. Well, PCT is just it's not the complete story. There's another aspect to this. It's the pathogen identification. And this is now a story about integrating molecular point-of-care testing, specifically using PCR. PCR is great because we know how PCR works. We've learned a lot about PCR since it was discovered in the 80s. So we definitely know how PCR acts, how well it performs, and can be refined. So in this case, we see that adoption of PCR testing, especially at the point of care and so forth, for pathogen detection can decrease unnecessary antibiotic use. How so? Well, if you don't have a flu infection, you probably don't need oseltamivir. If you don't have strep A, then you don't need antibiotics for that bacterial pharyngitis. So this is a story of how point-of-care PCR pathogen detection can enhance antibiotic stewardship in outpatient clinics and the emergency department because now we have PCR tests that can be deployed as a wave technology that has a fast turnaround time to ultimately help clinicians to decrease unnecessary antibiotic use, decrease unnecessary oseltamivir use, and decrease multiplex PCR expenditures. So it actually optimizes some of the tests we actually do that are extremely costly in healthcare today. So here's some data. So this is the concept model for integrating molecular point-of-care testing using PCR for influenza patients. This is data from 5 hospitals in Chicago and Nashville over a decade, so 2002 to 2012. Over 2,000 patients, 21% of which were in the ICUs. And you can see that some of the metrics, some of the measurements that were done were blood culture, urine, antigen, PCR. And what's striking here is that 62% of all these results were negative for a pathogen. This shows that we're actually doing a lot of tests that ends up being negative, which means these people may not need any of these antimicrobials that could have been prescribed empirically. What's also drove the implementation of this, in addition to having objective means to drive down the necessary antibiotics, is we see that in January 2017, FDA finally released the much-awaited for FDA reclassification of antigen-based influenza tests because of how bad they performed. So by 2018, most of us rushed to the store to go buy these devices that could actually replace them, and it was used to great effect. This was a study published in 2017 looking at the pediatric emergency department, the impact of rapid molecular respiratory virus testing in real-time decision making. And in this case, they discussed how would a hypothetical viral molecular point-of-care test that evaluate RSV, respiratory syncytial virus, flu AB, that would have results within 20 minutes affect care. They looked at interviewed physicians and so forth over a short period of time in 2016, and used these and looked at these nasal pharyngeal swab respiratory virus PCR in children with less than 18 years for that. And they found with an N of 61, 64% of these cases would have had change management. That's profound. 13 to 18% fewer chest x-rays, blood draws, and urinalyses, 5% fewer admissions, 15% less antibiotic use, 8% more appropriate oseltamivir use. So very important. But now for a real-world study where prospectively they looked at ED physicians in Hennepin County. This is over February 2014 to May 2015. They're using a best-in-class PCR platform for flu AB, roughly 30-minute turnaround time, and they found that influenza diagnosis changed treatment plan in the vast majority of cases. So this allows clinicians to have a very objective means to change care rather than empiric care, which I'd like to describe to my residents that it's effectively educated guessing. It's based on your experience, but sometimes you get it right, sometimes you get it wrong. So this test is equivalent to a centralized lab with sensitivity and specificity of over 98%. And you can see here that there's a gain in terms of revenue of $377 or savings in this case. There's a decrease in cost, about $64 per patient, decreased no use of additional tests, increased or optimization of antimicrobial and antivirals, about 53%, but ultimately out of 143 patients, the cost per patient savings was about $200. Great, $200, but that's cumulative if you think about it. So it will help you over time. So how do we implement this? The CDC recommends that we perform molecular testing in this case when you meet the following criteria, and ask yourself, does the patient have signs and symptoms suggestive of influenza, including atypical clinical presentation, or findings suggestive of complications associated with influenza? If they don't, influenza testing probably not indicated, consider other etiology. If yes, ask yourself, is the patient going to be admitted? If not, is the test going to make a change in management? If not, you probably don't need testing. You could start empiric treatment if the patient's a high-risk group or have progressive disease. Now, alternative, if it is going to change management or if the patient's going to be admitted, yes, you can start testing for them. You can start empiric treatment and so forth, but you have to make sure that you know what you're interpreting from those results as you move forward. So at UC Davis, we adapted this algorithm a little bit, kept it a little bit more simple. We asked, do these patients, especially adults, have respiratory symptoms? Are they going to be an inpatient? Are they going to be patients that are going to be admitted? Are they immune compromised? Perform multiplex PCR because we want to make sure we capture the bigger picture. However, in the vast majority of patients, are you low-risk outpatients? Are you an ED patient not needing admission? Is it flu season? And if yes, then pretty much ask yourself, will flu results influence management? And if yes, go ahead and run the test. We kept it simple for people. And with this very simple rudimentary algorithm, we were able to reduce ED demand on multiplex PCR by 40%. And for those of you that run this platform, it's not cheap, right? So we saved, in this case, from a very short period of time, about 4 months, $37,000 of unneeded multiplex PCR testing for respiratory diseases. Among ED patients, by moving to the point of care rather than centralized multiplex testing, we were able to reduce the actual therapeutic turnaround time by an average of 4.8 hours. This is not regular turnaround time. This is therapeutic turnaround time. That is the time from test order to treatment. So we were greatly able to reduce that. We were also able to improve patients and move them out of droplet isolation. In this case, our infectious disease team asked if they can run a PCR test more quickly to see if they can move a patient out of droplet isolation who had flu beforehand. And then, interestingly, the 20-minute turnaround time for these molecular tests actually forced some of these providers, instead of giving drugs unnecessarily, ordering tests unnecessarily, they thought about it, and it's high prevalence flu season. They can make a clinical decision by looking at the patient. Yes, you have flu. I'm going to treat you correctly. And that's what CDC recommends. During high prevalence conditions, you don't necessarily need a flu test to tell you that a patient has the flu. So health economics and value. PCT, yes, it could be more expensive than CRP, but does it generate better clinical value? Molecular point-of-care testing enables early treatment, reduce unnecessary antibiotics, and does it really prevent hospitalizations? Well, the data does support that. But there's some caveats that you all have to kind of think about. Most facilities have limited ability to assess the impact. I have an entire team of 6 personnel to actually do quality work to identify what we've done to improve the quality of patient care at our institution. Other places may not. And with these novel testing methods and the impact of antibiotic stewardship programs, it may be hard to assess. So that's why we present this study for you, these studies for you today. Heterogeneity of study designs. So focus on cost-based outcomes. So there's a lot of studies that look at one thing versus another. And some studies don't even actually consider antimicrobial resistance, patient outcomes, safety, patient flow, institutional isolation, and regulatory aspects. And factors that impact value, frequency of tests, cost of discontinued antibiotics, et cetera, and algorithms, these are ultimately things that can ultimately affect the performance of your studies and how you would implement them and so forth. Here's some additional data that could help you move along. It's from Bulk et al. In 2017. This is a retrospective study, propensity score matched multivariable analysis. It's from a Premier Health database with over 33,000 patients admitted to the ICU with 1 or 2 PCT collected on day 1 versus greater than 98,000 patients without PCT tested. And you can see in the PCT and no PCT groups, there's a striking and statistically significant difference. In this case, a reduction in length of stay, ICU length of stay, reduction in total cost, reduction of ICU costs, reduction of pharmacy costs. We see a little bit of a rise in laboratory costs, fine, we do more testing, but we see also a reduction in total antibiotic exposure. So overall, healthcare wins with a modest increase in laboratory costs. That is what it is. But ultimately, we could say that with PCT, with these technologies, it reduces antimicrobial therapy days by 47.1%, reduces mortality due to infectious diseases by 62%, 50% reduction in 30-day readmissions, and 64% reduction in C. diff infections, 50% reduction in adverse events, and so forth. So ultimately, this leads to this experts' consensus of antibiotic stewardship interventions in acute care settings. So in this case, it evaluates how we should utilize these things and focus on how we can days of therapy admission, days of therapy and patient days, adherence to guidelines, and looking at if there's excess drug use, are there de-escalation being performed, and so forth, and how many numbers of occurrences that occurred with this. And these technologies help with this actual use from this panel. So ultimately, the role of antimicrobial stewardship is just not about these actual technologies. These technologies work with the actual teams that are involved here and so forth. So rapid diagnostic technologies can greatly assist in optimizing care with patients with infectious diseases paired with these technologies and these ASP teams. Ultimately, this reduces the time to appropriate therapy, reduces mortality, improves cost savings, reduces costs for infection control and pharmaceutics, and reduction in additional laboratory tests and lengths of stay. So to close out, 5 critical elements: plan, champion, engage, and standardize and disseminate. It's all about planning. You're just not going to switch on the test tomorrow and hope for the best. We want to be able to champion, so have people pushing these efforts, because doing these tests in a vacuum and implementing these programs in a vacuum won't work because you won't have adherence. That's all about protocol adherence. You got to engage people, nurses, patient care teams, pharmacists, physicians, laboratory, IT, and standardize. You got to integrate this with EMR. You can't just give a person a piece of paper and tell them this is what the result is and hope that they actually will act accordingly. And ultimately, you want to standardize this process. And lastly, the dissemination of policy, education, and have feedback, because you don't want to have mission creep, because you want to have these to be sustainable over the course of time and not have creep of increases in antibiotic use just because people forgot what we were doing in the first place. So with that said, I'm happy to take questions, and I thank the AACC for supporting this talk with LabLeaders.com, and we're happy to take questions. Thank you.
Thank you, Dr. Tran, for sharing that excellent presentation with us. I would like to remind everyone in the audience that if you'd like to submit a question, please do so and submit it to the Q&A dialog box in the right-hand corner of your screen. Now, before we begin the Q&A, we would like to take a quick poll about today's program. On a scale of 0 to 10, how likely are you to recommend this webinar to a friend or colleague? We would greatly appreciate it if you could take just a moment to enter your response in the right side of your screen. LabLeaders and AACC strive to continue to bring you the relevant and actionable insights to empower laboratory professionals. So in just a moment, we will begin the Q&A portion of our program. All right. We are going to begin the Q&A portion. Here at AACC, we are having some technical issues, but nevertheless, we will begin the Q&A portion with Dr. Tran. Dr. Tran, here is the first question. A recent New England Journal of Medicine paper suggested PCT was not effective. What are your thoughts on this paper?
Oh, that's a great question. I'm glad someone asked that, and I'm actually surprised that this is still an issue. But for the most part, it comes back to that statement very early in my talk that you need to have compliance with your protocol. And those early studies I presented had about 90% compliance. If you read the paper in New England Journal of Medicine, Devil's in the Details, there's two problems. The first is there is a very low compliance rate, far lower than you would have. So if you don't have compliance, then how are you going to be able to tell people that this biomarker doesn't work? The best you could say is that people weren't compliant to use the biomarker. The other aspect is that this test was performed with a non-automated system and also not integrated with the EHR or laboratory information system and so forth. So in some cases, I believe that they actually report results on a piece of paper. So, I mean, that's kind of going back to the dark ages in terms of how we used laboratory medicine, so especially for a time-sensitive test. So if you have lack of compliance and slow reporting results and inefficient use of reporting results, I'm not surprised that the biomarker didn't work. But if you have a good integrated system, and we do live in 2018 and very soon 2019, we live in a very integrated process, and if we take the time to educate, work with team members, have champions, plan, we're going to be able to execute any of these tests very effectively. Otherwise, it's just inefficient.
Thank you, Dr. Tran. The next question is, can procalcitonin and molecular point-of-care testing be used to promote antimicrobial stewardship?
And I hope the story of this presentation is pretty much emphasized that. And I would say 100% yes. I think antibiotic stewardship alone won't be able to do it without PCT and molecular testing, and molecular testing or PCT alone can't do it without ASPs. So they are part of the same team, and they have to be able to work together because the test provides the objective data to guide ASPs, and ASPs are the means to push these efforts to be able to do that.
The next question is, it can be challenging to establish an antimicrobial stewardship program. Could you list some strategies that we can use to start this process?
Sure. And I just do want to note that my screen just blanked out, but assuming everyone can still hear me, that in this case, some key things is obviously planning, but I really would say one of the most important things, and we were one of the first sites most recently reliving this effort again, implementing a high-sensitivity troponin assay. It's all about building partnerships and teams. It's all about building not just partners, I'll be honest, building friendships with other services that use us. We do not work in a vacuum in laboratory medicine. We want to be engaged. You have to be on the committees. You have to be there and educate people why laboratory tests are important. It's not just another biomarker that you buy, that's another result. We want people taking for granted these tests, but I think the key thing is engaging people and educating on the best use. Otherwise, we leave people to their own imaginations and innovation, and sometimes it doesn't really work out, and then it's a lot more work to actually have to re-educate people. So it's all about education and then teamwork.
All right, Dr. Tran. Well, this concludes our Q&A. So I'd once again like to thank you for providing this excellent presentation. And to everyone in the audience, if you'd like to request of today's slide deck, please visit the LabLeaders.com website and select the Connect button. And thanks to all of you for participating. We would like to invite you to mark your calendar for next month's webinar, which will happen on January 2nd. The title of that webinar will be The Hidden Value of Laboratory Medicine, How to Leverage Laboratory Stewardship to Your Advantage. And the speaker will be Dr. Jeffrey Pearson. Now, when you close out of this webinar, you will be taken directly to the AACC website where you can obtain your Accent Continuing Education credit. And later today, you will receive a message from AACC with the playback to today's program. If you have any questions following this program, please call our customer service line at 1-800-892-1400. So thank you again, and we hope you all have a wonderful rest of the day.